Welcome you all to the afternoon session. And topic of discussion for today is regarding the salivary gland disorders. The major salivary glands and the minor salivary glands, that will be dealt later. And the importance of the salivary secretion, okay, starting from your wettening of the oral cavity and enhancing your digestion, okay. The importance of the salivary gland can be appreciated in this topic. And the salivary glands, as I told you, can be major salivary glands. The main chunk taking care of your parotid gland. Next is the submandibular and the sublingual. These three form the major salivary glands. And the minor salivary glands is your present in the labial, buccal surfaces, underneath your tongue, the glossopalatine, the lingual, glands of Blandin and Nun, von Eber's gland, and the posterior salivary glands. These are minor salivary glands, or otherwise called as accessory salivary glands. And it can be disorders can be categorized into the following. It can be the functional disorder, that is, or can be due to obstruction, that is called as the obstructive disorders. And if there is any infection to the salivary glands, okay, infections or any systemic problem, systemic diseases of your salivary glands. The fourth one is the idiopathic diseases. Fifth one is the autoimmune disease of your salivary glands. And the last one is your neoplasm of your salivary glands. Okay, the disorders are classified into the followings. Now, coming to the first, that is your functional disorders. Okay, one is the developmental anomalies. Most commonly is the aberrant salivary glands, aplasia and hyperplasia, accessory ducts and diverticuli. That is any deformity during the development of the salivary glands. That is the developmental anomaly. One is the aberrant salivary glands. The second is the aplasia and hyperplasia. Third one is the accessory ducts. Now, this is regarding to your developmental anomaly. Next is obstructive conditions. Any obstruction in the flow of the saliva can be a simple xylolith or a mucocele. It can be a xylolith, that is the xylolithiasis, and the mucocele. The one is necrotizing cylometroplasia. This is with regard to any obstruction in the salivary fold. The third one is your inflammatory disorders. As I told you, due to any viral infection, most commonly the mumps and HIV associated salivary gland viral infection. Your bacterial can end up with siladenitis. Okay. First and foremost is any developmental anomaly, or if there is any obstruction to the salivary flow, and if is there any infection or any inflammation of your salivary gland. It can be a viral infection, mumps, or it can be due to HIV associated viral infection. Okay, these things you should keep in mind. And as the neoplastic diseases can be benign or malignant, can be in the epithelial of your salivary gland, or it can be in the mesenchymal of your gland. Okay, neoplasm, that is, can be a benign lesion or can be a malignant lesion of your salivary gland. The next one is degenerative conditions. Okay, degenerative condition most common is the Jogren Syndrome, and any ionization, any ionizing radiation, any after radiotherapy, there can be problem in the salivary secretion, that is ionizing radiation. The last one is the xerostomia, that is decreased or loss of salivary secretion, called as xerostomia. Now, before going into the disorders of the salivary glands, basic thing, the secretion, that is the saliva secretion, is a clear, slightly acidic mucoserous secretion, which provides the chemical milieu of the teeth and oral soft tissues. The whole salivary complex is a mixture of fluids containing high population of normal oral bacteria, desquamated epithelial cells, and transient residues of food and drink following their ingestion. Okay, when you see the composition of the saliva, it is a complex mixture of fluids ranging from the high bacterial strength that is there in the saliva. The desquamated epithelial cells forms the major chunk of your salivary composition. Salivary glands are essentially exocrine glands that secrete this valuable oral fluid through a duct system. Based on the types of the secretion, it can be a serous, it can be a mucus, or it can be a mixed. Okay, the major salivary gland, that is the parotid gland, purely secretes a serous form of a fluid. The submandibular, predominantly serous. The sublingual, predominantly mucus secretion. And based on the secretion, okay, your parotid is a purely serous salivary gland. Your submandibular, sublingual is mixed salivary glands. It can be categorized in that form also. It can be either a serous salivary gland or it can be a mixed salivary gland. And the accessory salivary glands, your labial, buccal, lingual, predominantly it is a secretes mucus type of secretion. And the palatine, glossopalatine, purely it is a mucus secretion. The posterior part of the tongue, it is purely mucus. And von Ebers gland is purely serous type of secretion. And this is regarding the type of secretion of each and every salivary gland. And the location, okay, the parotid gland is located anterior to the external auditory meatus and the mastoid process, that is in front of your Here, that is the position of your parotid gland. Inferior to the zygomatic arch. Lateral and posterior to the ramus of the mandible. That's it. Okay. And superior to the masseter muscles. That is the position of your parotid gland. Okay. The duct is called as the Stenson's duct. Okay. The other one you should worry about is the parotid fascia. Superior to the okay. This is the position of your parotid gland. Now, the next one is the submandibular gland. The superficial, it consists of two parts. One is your superficial part, lies in the slight depression on the medial part of your lower border of the mandible and extends below to the submandibular triangle. Okay, that is the superficial part. The deep part lies beneath the oral mucosa in the floor of the mouth. That is the mylohyoid muscle. It communicates with the superior lobe around the posterior free edgeoid of the mylohyoid muscle. The duct is, that is the Stenson's duct. The submandibular duct is Wharton's duct. It passes forward from the deep part of your submandibular gland along the floor of the mouth to open into oval cavity at the sublingual papilla under the tongue. Opens up beneath the tongue. That is at the sublingual papilla under the tongue. Here where the submandibular duct opens, Wharton's duct. The sublingual glands, they are the smallest of the major salivary glands and they lie beneath the mucous membrane of the floor of the mouth. It opens through multiple ducts into the submandibular ducts. The duct name is the Bartholin's duct. It is the main excretory duct of the submandibular gland and may open into the submandibular duct of the oral cavity with a separate sublingual papilla. Now, when you see this picture, you can very well see the superficial part of your submandibular gland associated with the mylohyoid. Okay, the deep intraoral part of your submandibular gland. Okay, and this is the hyoid bone. And considering the minor salivary glands, okay, mainly in the superior and inferior labial surface, in the cheeks, buccal surface, lingual beneath the tongue, palatine, hard palate, soft palate, and the uvula, and the glossopalatine. These are the minor salivary glands: labial, buccal, lingual, palatine, glossopalatine. These are the minor salivary glands. Now, considering the vascular supply to the salivary glands, the parotid gland, external carotid artery supplies. The venous drainage is external jugular vein. This is regarding your parotid gland. And the lymphatic node is the parotid nodes to the upper deep cervical nodes. The submandibular is supplied by facial artery, that to lingual artery. Venous drain is common facial vein or the lingual vein. Lymphatic is through submandibular lymph nodes. The sublingual gland, lingual and submental arteries, lingual vein. Clear? Profuse salivation is seen in patients with AV metal poisoning or in MR children after lithium medication. Siluria. If the local factor is removed, this drooling can be eliminated. Removal of dental disease and nasal airway obstruction that contributes to drooling should be eliminated. If there is any nasal obstruction, then you can expect a profuse salivation. And if the local factors or the removal of your airway obstruction, then the amount of salivation will decrease. It will become normalized once when the local obstruction or local factors is removed. And the symptoms: mouth odor, speech difficulty, burning tongue. Okay, the patient is under any antidepressants, anti-hypertensive drugs, or in the reduction, if there is an antimicrobial action of the saliva leads to oral candidiasis. If there is any infection, or if there is any, the patient is a excessive smoking patient, a patient with a mouth breathing abnormal oral habit, or the Jogren Syndrome, or patient under any medication, that can be due to age. If the salivary flow is decreased, the patient ends up with xerostomia. And looking into the symptoms, okay, you can most commonly expect a pale fissured tongue if the patient is having any severe dry mouth, total absence of saliva. They end up with a fissured tongue, pale fissured tongue due to severe dry mouth. And the treatment part will be maintenance of your oral hygiene and use of silagogues, most commonly your pilocarpine. And to avoid drugs that may produce xerostomia, avoid dry or bulky foods. High fluid intake or rinsing with water, avoid alcohol, smoking and sugar, take protein and vitamin supplements, maintain the optimal oral hygiene or air avidity, use topical application of Vaseline. These may, and the other part is patient with a complete denture. Okay, this picture shows the pattern. A dry mouth with, if there is dry mouth, then eventually patient's denture won't stay. There won't be any retention for the dentures, and easily abraded mucosa, and frictional irritation to the mucosa, and intolerance to denture wedge. That means there will be complete dry, no retention for the denture, and difficulty in using the denture. Patient won't have tolerance. Okay, there will be irritation to the mucosa. Mouth ulcers will be common. Painful mastication, and patient will be, the complaints of the patient will be totally negligible. Very difficult to wear the dentures. This picture, the fissured tongue with a strawberry tongue. Most commonly, the clinical picture of your tongue depicts how does your strawberry fruit look like. This is the dorsum of your tongue, wherein severe dry mouth is there. The palliative treatment will be topical application of this gels, various gels. Now, the next part is your silolithiasis. These are nothing but calcified organic matter that develops in the duct of the salivary glands, caused due to deposition of calcium salts on the nidus, most commonly seen in the Wharton's ducts. Wharton's duct is the duct of your submandibular salivary gland. Most commonly, your cylolith is associated with Wharton's duct. Okay. Mostly seen in children and adults. Unilateral involvement of adult column is common. The affected gland is swollen, painful. The overlying skin will be reddish and erythematous. Low-grade fever with trismus, difficulty in mouth opening, and a purulent discharge is observed from the duct orifice when the gland is swollen up. The entire gland will be swollen up with a purulent discharge in the orifice of the duct. The treatment part will be maintenance of oral hygiene, soft tissue, soft diet should be given because chewing will be more painful. And the other one is any obstruction can be due to mucocele. Mucocele is the swelling caused by a pooling of saliva at the site of the damaged accessory salivary gland due to trauma. Mostly seen in the lower lip, followed by the floor of the mouth, tongue, and the palate. These are the areas most commonly your mucocele will apply. Mucocele can be two types. One is the retention type. Second is mucus extravasation type. Clinical appearance, bluish swelling. It will be fluctuant. On palpation, it will be fluctuant. That is the clinical feature of your mucocele. The ranula, otherwise called as mucocele, blue or purplish red enlargement occurring in the floor of the mouth, ranula. And the treatment part is marsupialization of surgical removal of your ranula. The other condition is the necrotizing cylometroplasia. It is caused due to trauma resulting in ischemia of the salivary glands. Any trauma to the oral cavity can expect necrotizing cylometroplasia of your salivary glands. It will be like a tumor-like mass, frequently with a deep surface ulcer, very painful ulcer. And the treatment part will be debridement of your lesion, but healing will take a minimum of 6 to 12 weeks. That too mostly in the heart palate. Most commonly, any injury to the heart palate will end up with a necrotizing cylometroplasia. The treatment will be debridement of the oral lesion, and it will take at least a minimum of 6 to 12 weeks of healing period. Now, the other condition with regard to the inflammatory disorders, the mumps, the viral infection, with sudden onset with fever, headache, and painful swelling of the parotid glands, and most commonly affects the children and in the growing individuals. The duct, the Stensen's duct of the parotid gland will be swollen and erythematous, but there won't be any purulent material as it is seen in the submandibular gland. The condition is a self-limiting, so it resolves spontaneously within 5 to 10 days. And one thing is, it should prevent any dehydration. Okay. Self-limiting viral infection. Okay. Resolves within 5 to 10 days. Only thing is, you have to maintain patient doesn't go in for severe dehydration. And the next part regarding the autoimmune disorders, most commonly the Jogren Syndrome, and it is associated with a keratoconjunctivitis, sick of dry eyes and dry mouth. This Jogren Syndrome is associated with dry eyes and dry mouth, and autoimmune condition and causes destruction of the salivary and lacrimal glands. See, this picture shows the dry eyes and the dry mouth. Dry mouth will eventually end up with increased dental caries. And this is the picture with, you can see multiple caries tooth, the maxilla and the mandible. You can see the fissured tongue, the strawberry tongue, and the dry eyes, the clinical. Okay, treatment is you to ocular lubricants and artificial tears. Salivary substitutes can be given to the patient. Antibiotic therapy in rehydration of the patient to stimulate the salivary flow, and frequent drinks water should be given to wet the mouth continuously. Any topical application, see to that patient doesn't go in for any dehydration. That will worsen up the condition. Now, regarding the carcinoma of the salivary glands, it can be acini cell carcinoma or squamous cell carcinoma, salivary duct carcinoma, the adenoid cystic carcinoma, the basal cell adenocarcinoma, or the various carcinomas. The adenomas most commonly is the pleomorphic adenomas, myeloepithelioma, basal cell adenoma, Wharton's tumor. These things the most commonest. Now, benign can be benign or malignant. Benign is a slow growing, okay, soft rubbery consistency, usually encapsulated, does not ulcerate, not associated with any nerve damage or nerve palsy. Now coming to the malignant part, fast growing, maybe hard in consistency. And the Wharton's tumor, clinical is superficial lying beneath the parotid capsule, protrudes through it. Wharton's tumor. It causes soft, painless swelling, but sometimes can be painful on rapid expansion. It is encapsulated tumor. The pleomorphic adenoma, most common of your benign salivary gland tumor. Basically, a proliferation of myeloepithelial cells, wide spectrum of epithelial and mesenchymal tissue components surrounded by a definitive capsule. So, has a very good prognostic value. Now, the clinical features. Small, it's a painless nodule which slowly increases in size with the intact structure. Palate is the most common site of occurrence. The treatment is the complete surgical excision, and the lesions in the superficial lobe, superficial parotid removal with preserving the facial nerve. And the tumors of the can be total parotidectomy. The submandibular gland tumors, total removal of the gland is mandatory. And if it is in the tumors of the palate, it can be total excision. Okay, these are the treatment options. And the next entity is the adenoid cystic carcinoma, also known as adenocystic carcinoma. And it's a slow growing tumor characterized by proliferation of the ductal and the myoepithelial cells, and more commonly seen in females. In the older individuals, slow growing, and it is fixation to the skin. Surrounding structures develop in later stages. It may end up with a nerve damage, so there will be a facial nerve paralysis. Treatment is the surgical excision. is the only treatment option. And thank you one and all for your patience in listening to this session regarding the oral cavity.